Just listening to everything you have to say.
Absorbing it through your skin.
Exactly.
The GI tract. Or never mind. Okay. Hi.
Papa, you're the
Yes. Yes.
That's exactly like John.
Hey, I have a class. Can you go?
No, I want to hug you.
Okay.
Hi. Hi.
Hi.
All right. Next is specific signs and symptoms between ARDS and respiratory failure. Remember that both are respiratory failure states. The difference is what did I say? The difference is ARDS is a progressive form of respiratory failure. So meaning although both will have low PaO2, high PaCO2, there is a difference now when the patient develops ARDS because now you have that capillary leak syndrome now occurring. That's why the lung becomes wet. Pneumonia vaccination. This is the concern is I know what I taught in NUR 104. I'm not sure if this was covered. Did you talk about indications for pneumonia vaccination from the CDC website?
Yes, we did.
You did, right? So between PCV 13 and PPSV 23, do you know when each are given? Because you have two vaccines currently. We have PCV 13, which is pneumococcal
We didn't learn that.
conjugate, and then you have the pneumococcal polysaccharide vaccine.
Because you sent us a PDF with it before.
Okay, let me send it again.
Professor,
Yes.
are you also going to send
Send what?
the hard block information that's not in the book?
Okay, yeah. All right, I found it. Vaccines. Okay. Do you see my screen?
Yes.
CDC, vaccines, and preventable diseases. All right, I'll send you this. Look at only the adult, which is right here. This would be almost midway through the website or through the
I
web.
only see the blueprint.
Yeah, we can only see the blueprint.
Ta-da!
Okay.
Okay, 19 adults, 19 through 64. I'll send the link directly to this webpage. So this for the general guideline for pneumonia vaccination is the first qualification is age. All adults 65 years or older must receive the vaccine. So I'll go straight to the end first. Okay, this one says 65-year-old here. Okay, so this one says adult 65 years or older without immunocompromising condition, meaning the adult is otherwise healthy. Okay, their only risk factor is they're 65 years old. Okay, so granting that they don't have any of these, no immunosuppression, no cochlear implant history, no CSF leak history. So a healthy 65-year-old. The standard recommendation is 1 dose of PPSV. Between PCV 13 and PPSV 23, I'll just call them 23 and 13 in the interest of time. So 23, the numbers correspond with the number of strains that they protect the patient from. So when you hit 65, you will receive the 23 vaccine. If the patient has never received the 13, meaning they probably were on their way to 65 when the 13 vaccine came out, because the 13 and 23 came only in the last decade. In the previous decade, we only had one vaccine, which is the pneumococcal vaccination. There was just one for everybody. Now we have two. So we have the 13 and the 23. So again, if you grow old, you hit 65, you will be offered the 23. If you've never received a 13 before, you will get 1 dose. The 13 is only given once to any person. Okay, so a person can only receive the 13 once. There's really no benefit to getting another one. The 23, however, can be given again. So let's say first scenario, Miss Clarine got old. She became 65 years old. She's never had a pneumonia vaccine before. So I will offer her the 13 first because she's never had it. So I'll give her the 13 today. 1 year later, she's now eligible for the 23. So in a healthy, otherwise healthy person, there should be 1 year between a 13 and a 23 dose. That's one rule. Another rule, again, which I already mentioned, a person can only receive 1 dose of the 13. Again, there's no benefit to getting a second one. Are you with me so far?
Yes.
Yes.
All right, that's one scenario. So let's say when I admitted Mr. Johnson, Emmett, he's only 63. Is he eligible for a pneumonia vaccine? Is he eligible?
No, it's
No.
For,
not based on his age, right? So he's only 63. He's not eligible to receive the pneumonia vaccination. However, that's not the end, because based on age, he's not. But based on the other medical conditions, which is now the second criterion, now we go to ages 19 through 64. So this is now where this part comes in. So Mr. Johnson is 63 years old. He's not qualified for the vaccine based on age, but I'll make sure he doesn't qualify for the other criteria, which is now he's between 19 and 64. So I'll ask him, Mr. Johnson, do you have a history of CSF leaks or cochlear implant? CSF leaks, these are obviously people who had some type of head injury, for instance, or had a shunt put in for whatever reason. No, a VP shunt, ventricular peritoneal shunt, or maybe they have a hearing problem as a child, usually children with congenital disorders, namely Down syndrome, for instance, trisomy 21. If they have if they're deaf, born deaf, one of the treatments is to put a cochlear implant. And of course, there's a connection between our ears and our upper respiratory tract, right? So they are very high risk for infections if they have that, because they get a upper respiratory infection, then they'll get an ear infection, definitely. So they are prone to infections either way. So if the patient has either of these, which puts them at a immunocompromised state, or a um, highly likely to get a upper respiratory tract infection, because you know already by now that upper respiratory tract infections can lead to a lower respiratory tract infection, which is now pneumonia. Okay, so that puts them, makes them a candidate for pneumonia vaccination. So here we are. So if they have these, then what is the recommendation? They should get a 13 and a 23 if they are between 19 through 64. These should be given 8 weeks apart. So you always give the 13 first, and then 8 weeks later, they get a 23. Again, this is for adults 19 through 64 having history of these two conditions right here. Now, if Mr. Johnson, he's 63 currently, when he turns 65, is he eligible for another 23 based on his age?
Yes.
So,
Yes.
Yes, he is.
Yes.
This
Yes.
time based
Yes,
on
he
his age. However, since he got the 23, the PPSV 23 at age 63, he's 63, right? Yeah, so he's 63 years old. He got the PPSV 23. There has to be 5 years in between. So when can he get the second PPSV 23 based on his age of 65 now? He got it.
68?
Okay, very good. So he now gets it once he turns 68. Okay, that second dose was not because of the CSF leak or the cochlear implant. That's
Based on the age.
exactly. So that's now based on his other new risk factor now, which is his age, which is 65.
Okay.
Yeah, the only reason we gave it as 68 was because it was too soon from when he got it first. So there has to be 5 years in between doses of 23.
Okay.
If you're wondering why is there 8 weeks between this 13 and the other 23, whereas in the first scenario with Joanna, it was given 1 year apart. Well, in Joanna's case, she wasn't immunocompromised, so she was healthy, so she didn't need them to be given too close. Okay, but this person right here, Mr. Johnson, has immunosuppression, or he is immunocompromised because of these conditions. So that's why he has a higher risk. So that's why we gave these two 8 weeks apart. Next condition. If you are 19 to 64, you have any of these conditions. You have HIV, you have sickle cell, you have leukemia, or any other cancer that puts you at immunosuppression. Okay, so these obviously are immunocompromised. Sickle cell, because sickle cell patients receive hydroxyurea, right, which is an oral chemotherapeutic agent. So that's why they're put under immunosuppression. So any of these patients aged 19 to 64 will receive 113 and then 2 doses of 23. Again, they are 19 to 64. So let's say our patient is Al-Haji. Okay, so Al-Haji is HIV positive, not from sex. Okay, he got it from needle stick. Okay, he got a needle stick infection. Unfortunately, the patient was HIV positive. So now he will get 1 dose of 13 and 2 doses of 23. How is it given? We always give the 13 first. And then when do we give the first dose of 23? 8 weeks later, because he's immunocompromised. And then when can he get this second 23 here? He'll be given
5
5
years later.
after.
Okay. So let's say Al-Haji is also 63 years old. So he gets the 13 today. 8 weeks later, the first of 2 23s. When can he receive the second recommended 23 based on immunosuppression?
68 again.
68 also. Now he's over 65. When can he get his 23 based on his age now? 73. Very good. So
Oh,
doses can a person possibly receive? The maximum doses of 23? Up to 3,
2.
specifically for Mr.
Oh.
Alhaji, because he's in a unique situation. He just because of his age, it was later in life. So he got a total of 3 doses of 23, but all of them were given 5 years apart, each one given for a different reason. So he got 2 doses of 23 based on his immunosuppression, and then we gave him a third one now based on his age. Are you clear with this so far?
Okay.
Okay, it's not really hard.
Yes.
Yes.
All right, so we have 2 more. Any smoker. So if you're a smoker, you're age 19 to 64, you have to receive, the recommendation is get 1 dose of 23.
When I know you said any smoker, but do you mean like vapes, marijuana, cigarettes, any type of?
Doesn't really, yeah, it didn't specify.
It doesn't mean.
Smoke, yeah.
Okay.
Mm-hmm. You could be smoking kale. I don't know if you can smoke kale, probably, but you're smoking something, so you're still gonna get 23.
Okay.
And then of course, when you get old, when you hit 65, as long as there's 5 years between this 23 here and then that 23 based on 65, that will be your second and last dose. Then finally, if the patient has any of these, alcoholic, heart disease, COPD, diabetic, the same thing as a smoker. They receive 123. And then when they get old, when they reach 65, as long as there's 5 years from the first dose of 23, then they can get that second and last 23. Any question? Alrighty then, let's go back to your blueprint. Okay, so chest trauma, this is chapter 32, the end of 32. Contusion, flail chest, rib fracture, pneumothorax, hemothorax, and chest tube management. And with the chest drainage system, the dry and the wet systems. We'll discuss the burns because this is the topic later at 6 o'clock. And for diabetes, we have BKHS. This is the causes, which are risk factors, signs and symptoms, lab results. So go back to chapter 64, comparison for both. This will include the ABG, the PA, and what else? Yeah, ABG findings, the severity of the blood sugar, the whether or not there are ketones, right? So follow that table comparing both, and of course the management. Same thing, same contents for between comparing DI and SIADH, still the causes, risk factors, lab findings, and management. And then the same thing for Cushing's and Addison's. So these are all the opposites now. And then same goes for hypo and hyperthyroidism, and then hypo and hyperparathyroidism. For stroke, we have a few questions explaining the purpose of the diagnostic tests. Of course, we have CAT scan for the diagnostic testing. Diagnostic testing is also covering the blood tests, so read that also, and drug treatment. Of course, there is alteplase in ischemic stroke, and then we have the afterward, we have the a clopidogrel, which is Plavix, and aspirin, and explaining all those to the patient and the patient's family. Distinguishing the types of stroke, ischemic and hemorrhagic. Ischemic also has embolic and thrombotic. So make sure you're ready to distinguish between them, the risk factors, and the management. TBI, that is the same, of course, because TBI has increased ICP. So recognizing the signs right here, which is line 53, and then we have management, drug therapy, nursing, and medical management. For increased ICP, we do have complications or findings as well with increased ICP. Not only the Cushing's triad, but the two abnormal positionings, which are the corticate and the cerebrate positioning. And part of your monitoring is the Glasgow Coma Scale scoring. The significance of hydration in stroke patients. What's the rationale for that? Why do we need to maintain hydration in all stroke patients? I guess you can also say the same in TBI, because they also have the same increase in intracranial pressure. Then finally, managing drug therapy for organ transplant. I don't have any question on signs and symptoms of rejection anymore. So I guess this is only chapter 17. So this should be chart 17-2, containing the CyTac and the PsychMyAs. I have one or two questions on which client to see first. I did not specify which concept, so this could be a stroke, diabetic, PE, dysrhythmic, or ACS patient. I don't know. And then finally, 5 math questions, which is your favorite, easiest questions you've ever taken. Any questions on your final exam? Just to make sure it's not Friday, your exam is on Wednesday, April 22nd at 6.
Professor, how many selectors that we have?
15.
That will be on there.
15.
Is it the same time?
What type, sir, exactly?
6 o'clock, yeah.
Oh, time, yeah, 6 o'clock. Wednesday, April 22nd.
No question on rejection transplant medication, Professor.
Say again, Magda.
You said there is no question on sign and symptom for rejection, but what about the medications? None?
Yeah, that's line 55, only the management. So management includes management of the side effects, okay, for the drug therapy. Because they cause immunosuppression, some of them cause liver toxicity, kidney failure, and all that. Okay, that's
Mm-hmm.
manage.
Okay.
Anything else?
I'm checking to see if you sent the PowerPoint. In my phone, I don't see it yet. It doesn't come up.
What PowerPoint?
On pneumonia and the heart blocks.
It won't be a PowerPoint,
Oh,
but I'll send you something.
thank you.
Alrighty. Alrighty then.
So what are we doing at 6 o'clock?
I don't know. What do you want to do?
Burns.
Yeah,
Okay.
I don't know what. You,
Professor, I'm sorry. I'm Johnny come lately. Next Friday, next Wednesday at 4:30, what are we gonna do?
we'll talk. You know,
Mommy?
I'll just because that'll be the last time I'll see Lauren. So kind of my separation anxiety interventions.
Separation.
Yeah.
I'll see you at the bedside in the nursing home.
Oh, come on.
Lauren, you bad.
Get out of here with that. Anything else, future colleagues?
Nope.
All right, so just promise me one thing.
Okay.
You will only take that NCLEX once and pass it once.
That's the plan.
Yep.
That's the goal.
Yes, sir.
No,
Yes.
you have to make that promise.
We
Right
got
now?
it. We got it.
You want us to promise right now?
If you promise to pass all of us, that's a
No, 20
guarantee.
years from now.
Exactly.
You promised that for us?
Well, have you learned anything from Mr. Escarda?
Absolutely.
Of course.
A
Yeah,
lot.
we've learned a lot.
Oh,
Mhm.
yes, Professor.
So much.
If you did,
Honestly,
um,
after being in this class, I think the NCLEX seems easy compared to.
well, tell me later when you've taken the NCLEX. So, 'cause I don't know if that's
Just don't change your cell number so I can text you.
Professor,
yes.
are we still getting advisors for the NCLEX or no?
Of course.
Oh, okay.
Mhm.
Thank you.
All right.
Isn't it our advisor already right now?
I don't.
Aren't they-
Mentors.
I don't know. I thought they were separate.
So I'm
Oh.
not really attending meetings regularly. So I'm.
What did you just say?
No, I'm a minimum wage worker for St. Paul's.
Oh, I have a question.
Yeah.
I don't know if I can ask, but I'm gonna ask anyway because it's a rumor. Are you leaving? Is this your last semester?
I'm still here, isn't it?
Oh, come on, Professor. You know what I
I was
mean.
curious about that too. I heard that you were leaving also.
What
Yeah.
do you?
We all heard that.
Graduating.
Because we want to know if it's true or not.
I don't know. I heard
Hmm.
I'm getting fired.
We need clarification, Professor. Clarification.
Again, what do you care? You guys are graduating.
And we care about the upcoming students.